Hi, and welcome to another installment of VCU Health Chat's Facebook Live. We are here today to talk with Dr. Michael Schechter, who is a professor and chief of pediatric pulmonary medicine at the Children's Hospital of Richmond at VCU. Thank you for joining us, Dr. Schechter.
Thanks for having me.
And today we're here to talk about asthma, which is what Dr. Schechter treats. But can you just start by briefly explaining what it is you do here?
So a pediatric pulmonologist is a pediatrician who specifically specializes in taking care of children with lung disease. And there are a number of different lung diseases that we take care of, like cystic fibrosis or lung disease that's related to prematurity. But the most common lung disease that we see in children is asthma.
Okay. Why are we talking about asthma? It's December. It doesn't seem like the most common time for asthma to occur. Can you tell me why we're talking about it now?
Well, asthma is the most common time or December is the most common time for asthma to occur. In children especially, but in adults as well, the most common trigger, and we'll be talking about triggers in a little while, but the most common trigger for asthma is getting a cold. And so colds come on in the winter, and most especially when kids first go back to school. And then in December in particular, when everybody goes around visiting between Thanksgiving and Christmas, and they go visit all their different relatives from all over the country. They trade all the viruses that are going in one neighborhood with viruses that are going in another neighborhood, and then they come home and they get sick. And for the patients, with children who have asthma, it's actually a very challenging time.
Okay. And I heard you have a special nickname. Can you tell us about that before we get started?
Okay, well, there are a couple of nicknames that I have, but the one that we'll talk about for today is that some people like to call me Dr. Schechter, the lung protector. And I even have one of the people I work with made up a nice little cape for me for when I'd like to go flying around taking care of children with lung disease. So I'll even put it on here for the rest of our talk, and we'll see if it allows me to go flying around or not.
All right. Okay, so you're also the director of the You Can Control Asthma Now program here. Can you tell me a little bit about what that is and what you do with that?
Right. So we have a lot of children here in Richmond who really have a lot of difficulties with asthma. And one of the things that we came to understand is that for many of them, the problem is that the children and the families have low expectations about what they can do if they have asthma. A lot of people think that, well, if they have asthma, it's going to really prevent them from being able to do many of the things that other children do. That it might prevent them from playing, it might prevent them from being very active, they may miss a lot of school, they may cough a lot. And so we wanted to come up with the name of a program that was positive, that gave a more positive message, and so that's why we came up with the name You Can. And what we're specifically doing, again, there are a lot of children in the community, particularly in Richmond, who have a number of socioeconomic barriers to care, and that's a big part of what asthma in this country is all about. There are issues with minorities where it's more common. There's issues in children in the cities who have socioeconomic stresses that interfere with their ability to get the care they need. And so this is a program that very specifically has been trying to address that. We have a nurse program manager who really helps to get everybody coordinated to be able to make sure that people are getting what they need. We have a social worker who helps us with patients who need a little bit of additional assistance with insurance, with housing, with food, and so on and so forth. So that's what the program is really focused on.
And did you start that program?
We did. We got started with it. When I first came here to Richmond, it was really striking to me that there was that sort of need. And so I spoke with the board of the Children's Hospital of Richmond Foundation, and they very generously gave us a grant to be able to start this program.
Excellent. And if anyone watching wants to learn more about it, is there somewhere that they could go for more information?
Well, we have a phone number, which is 828-YOU-CAN. I'm sorry, it's 628-YOU-CAN.
This is live, folks.
It's 628-YOU-CAN.
Uh-huh.
Okay, we have it right up there. Or you can also look on the web at that site over there.
Great, and we'll put that in the comment section as well, so that people can go there. So for the chat, we collected questions from parents of children who have asthma. We're also open to questions that you all might have, so please comment below for Dr. Schechter to answer your questions about asthma, and we'll try to get to those as well. So just to start off, can you explain the basics? What is asthma?
Okay, so asthma is a condition that affects the bronchial tubes in the lungs. So we have bronchial tubes that start off with our windpipe from our neck and then branch off almost like a tree into the lungs, and that's where the air moves in and out and gets into the lungs. And the problem in asthma is that there is irritation inside of those bronchial tubes. So we have a little picture here that I like to show people when I'm explaining to them what asthma is all about. So this is what the bronchial tube looks like in people who don't have asthma, and it's a nice big wide open tube that on the inside is a little bit like the inside of our cheek. On the outside you can see there's this muscle layer that goes around, and there's also some cartilage. Now in people who have asthma, they have, the medical term is inflammation, but really it's really like irritation, and that irritation is always there inside the bronchial tubes. And that irritation or inflammation is usually related to allergies. But because of that irritation, and there's a little bit of swelling that's always there because of that, because that irritation is there, when somebody with asthma is exposed to certain triggers of worsening, then the bronchial tubes tighten up even more, the muscle around the bronchial tubes get really tight, increased swelling occurs, and this is really where the people have the most symptoms. But for many people, even when they don't have what we call an acute exacerbation, they still will have some symptoms. In other people, they may not have symptoms, but that swelling and irritation is still there. And so if you have that sort of irritation or inflammation, you may or may not be aware of it all the time, but when you're exposed to certain triggers of worsening, that's when you really start to have what people think of as an asthma attack.
And something like a cold could be that trigger.
Right, and out of the different, there are a number of different triggers, and but viral infections or colds are really the most common trigger. But the other sorts of triggers that we commonly see may be exercise, or may be exposure to any kind of strong smell. And that strong smell may be something like cigarette smoke, or it may even be something that commonly is thought of as a pleasant smell, like heavy perfume or something like that. Or there may be paint fumes, cleaning liquids, anything that smells may be a little bit of a trigger for certain people with asthma. Sometimes if somebody with asthma is around, has a concentrated exposure to something they're allergic to, they're allergic to cats or something, and they're playing with the cat, they may get an asthma attack from that. Sometimes there'll be just some weather changes that tend to cause problems as well.
Right.
Those are some of the most common triggers for asthma.
Okay. All right, so we talked about the causes. What are the symptoms of asthma?
So the most common symptom of asthma is just a cough, and maybe it most commonly will be a kind of a wet, productive cough, but sometimes it could just be a frequent dry cough. And so there'll be some people who just, when they get a cold, the cold, rather than just staying in their nose, it sort of settles into their chest, and they'll be coughing for a few days or a week or 2 weeks or a prolonged period of time. And so that may sometimes be the only sign of asthma. The classic sort of symptom that people usually think about is wheezing, and the wheezing is because of this tightening in the bronchial tubes that causes that we have to then force air through a more narrow passageway, and that causes a noise, which is like a wheeze or a whistle. Okay.
Our
And then-
Facebook viewers are asking if you can just speak up just a little bit.
Okay, I can do that. We don't have a microphone, so I'll try and speak up louder. So and then the other sorts of symptoms of asthma may include breathlessness, especially getting out of breath with exercise, or when they get their colds and they start having some difficulty breathing. But it's usually brought out by exerting themselves by exercise in one way or the other.
Is there a difference between symptoms of asthma and symptoms of an asthma attack? Are they very different symptomatically?
Well, I think we can say that an asthma attack is just a worsening of symptoms. But again, there's different sorts of versions of asthma that we see in different children or adults. And in some people, they really may not have any symptoms whatsoever, and under ordinary circumstances, and then they will get a cold, they'll be exposed to a certain trigger, and then they suddenly start having increased cough or difficulty breathing. But then there's a number of people who do have some symptoms on a more regular basis, even when they're well. So they may just cough a little bit during the course of the day. Or they may cough in particular at night. They may wake up at night. Or they may have difficulty whenever they try to run around or something like that. And so for some of those people who have a little bit more severe form of asthma, they may always have symptoms, but the symptoms are mild, except then there's some exposure to a trigger, and then they start getting worse.
Okay. You talked about children and adults both have asthma. Can you speak on who can get asthma?
Well, of course, anybody can get asthma, but asthma tends to be seen in people who are allergic. There's a very strong association between allergies and asthma. That's particularly true in older children and in adults. Sometimes we'll see younger children who have a tendency to asthma, and they may not have quite as obvious tendency to allergies. And then the other group is children who were born prematurely. They're more likely to develop problems with asthma, whether or not they have allergies. But it very much tends to run in families, and so we often will find other family members when there's a child who has asthma.
Other family members who didn't know they had asthma before, or just who have asthma?
Well, oftentimes they may not know. Sometimes, for example, I'll hear about a parent who gets what is diagnosed as recurrent bronchitis. Now, as I already said, people with asthma, when they get a cold, they may just cough for a week or two at a time. And so in some cases, they may go to the doctor, and the doctor might say, oh, it's bronchitis, and miss the fact that it's asthma. And so sometimes I'll have a child who obviously has asthma, and what I'll hear is that one or both of the parents get recurrent bronchitis.
Yeah, that's actually what I was thinking when you described the symptoms of asthma that weren't related to an asthma attack.
Right.
It sounds like a cold or like bronchitis.
Right. Right.
How do you distinguish as a clinician between bronchitis and asthma? Is there an easy answer to that?
So an asthma exacerbation is really asthmatic bronchitis. So usually when we talk about bronchitis, people are thinking that it's an infection.
Right.
Okay. But bronchitis, just like any other itis just means inflammation. And so bronchitis technically is just inflammation of the bronchial tubes. And that may be from allergies, or it may be from asthma, or it may be from other causes of irritation, or it may be from a cold. But what I can say is this. Bronchitis is actually not a very common problem in children. especially recurrent bronchitis. So if somebody gets bronchitis more than once or twice, we immediately need to be very suspicious that what they have is actually asthma and not just repeated episodes of bronchitis. The one exception to that is adults who are smokers, because again, that's the other way that you get a lot of irritation of your airways by smoking. And so adults who smoke will get recurrent bronchitis as part of the damage that they're doing to themselves from smoking.
Yeah, don't smoke.
Right.
Just don't do it.
Don't smoke.
How many? You said that if the children get recurrent bronchitis, is it like within a year? If they get bronchitis twice, they should probably be coming in to get checked out for asthma, or what's the parameters of that?
Well, I think that's reasonable. If they have more than one episode of bronchitis, there should at least be a discussion with their pediatrician about why are they getting bronchitis like this.
Yeah.
They don't necessarily all have to come to see me, but I think that a discussion with the pediatrician about why is my child keep on getting bronchitis and what may be the underlying cause of that would be a really good conversation to have.
Right, that should be a warning sign of something.
Yeah.
So bronchital asthma, I might be misunderstanding this, is one type of asthma, or are there different kinds of asthma?
No, really. I mean, there are different kinds of asthma just insofar as we have some children who have relatively milder problems. So we talk about intermittent asthma versus persistent asthma. So when we talk about a child who has what we call mild intermittent asthma, what that means is that normally they're fine, and then they may get a cold, and then they'll have the cough, the bronchitis sort of thing, or some wheezing that may last for a few days when they have a cold. And then in between, they're fine, and it doesn't happen that much, and they don't get that sick when they get it. And then you have other children who just really have more severe issues, and so we start talking about them having persistent asthma, and those are the children who have a little bit more of this inflammation in the bronchial tubes that we talked about, who would benefit from the use of a medication to reduce that inflammation in order to treat them. And then some of them are mild, and some of them are more moderate, and then some of them are more severe. And so these are all, you can say these are different flavors of asthma. And then there are clearly some children who have much more problem with allergies, and some children who have less problems with allergies, all of whom may also have asthma. So these are all different ways that asthma can develop in different people. And then the other thing that makes asthma different from one person to the next is that you do clearly have some children who have recurrent wheezing and cough and congestion during the first few years of life, and then by the time they're getting into kindergarten, they're really doing a lot better. And then you have other children who may have it in early infancy and then continue to have it throughout their childhood and maybe even into adulthood. And then you have some children who don't have problems in early childhood and infancy, but then develop problems as they get a little bit older. So those are all different ways that asthma can show up. And again, there's still some things we don't know about asthma, and it may be that there are some underlying mechanisms in all of those different forms that are a little bit different.
Can asthma show up at any point in life, or is it usually during childhood? If you don't have it during childhood, are you in the clear?
No.
Okay.
So it's clearly more common in children, and it's not unusual for children to outgrow it. But we also see a number of other permutations and combinations. So you can see people who never had asthma as a child, who develop it as they get older. You can see people who had it as a child, seem to outgrow it, and then start having the problem again as they get older. So there's all different kinds of ways that it can develop and show up.
Okay. And I also had a question about the allergies. Is it environmental allergies that trigger it, like pollen and stuff like that? Or I don't know if this is a weird question, but can food allergies trigger asthma, or?
Not really. I mean, food, if you do have a bad food allergy, then as part of the bad allergic reaction you can have to a food, you can start to wheeze. But usually when we're talking about, again, the causes of that airway inflammation, what we're talking about is what you're breathing in. And actually, again, the most common causes in childhood tend to be dust mites and molds, and actually cockroaches for people who live in urban settings are a big
Really?
problem. Yeah. And then pollen allergy actually tends to be more of a problem in the kids as they get older. But the indoor allergens, the perennial allergens, as opposed to the seasonal allergens, are actually more commonly a problem in earlier childhood.
Interesting. All right, and no questions so far. Go ahead and comment with your questions if you're tuning in. We'd love to answer them. But now, so I see you have some medications there. Can you tell me a little bit about what are common types of asthma medicines?
Okay, so when we talk about how do we treat asthma, for the children who have what I talked about as just the mild intermittent asthma, in other words, they have a problem maybe when they get a cold or every once in a while, but typically they really are asymptomatic and they're doing okay. The cornerstone medication that we use is something called Albuterol. And Albuterol falls into the category, we like to categorize our medicines as rescue medicines and controller medicines. And so the main rescue medicine is Albuterol. And what Albuterol does when you inhale it is that it works immediately to relax the muscles that we talked about in the bronchial tubes that get really tight and tense when you're having an asthma attack. So if you're having difficulty with your asthma and you take some Albuterol within about 10 or 15 minutes, the bronchial tubes will start to relax. You'll breathe much more easily. And then the Albuterol usually lasts for about 4 hours and then it starts to wear off.
Mm-hmm.
So it has a quick onset of action, lasts for a little while, and then it goes away.
Mm-hmm.
So again, for people who just have very occasional problems with asthma, and when they do get it, the problems aren't that severe, then that's what we use.
Mm-hmm.
For the other children that we talked about earlier, and these are children who I tend to see more frequently, the ones who have symptoms that are there even when they're well, or the children who, when they do have their symptoms, get really sick and end up in the emergency room or end up in the hospital, then what we want to do is we want to use a controller medicine that tends to prevent them from having problems in the first place. And what the controller medicines do is they reduce that inflammation that makes the bronchial tubes more susceptible to developing that kind of tenseness and tightening when you're exposed to triggers. And so those controller medicines are medicines that you use every single day, because that's how you keep control over the inflammation in the bronchial tubes. You can't use them just as needed because they only work if they're used on a regular basis. In a way, you can almost think about, whereas the Albuterol you're using because it works immediately for you right now, the controller medicines you use and it's going to work a week from now. And so the puff that you're taking on the controller medicine right now is going to make you better a week from now. So you need to keep on doing that regularly if you have a tendency to have problems with asthma. So we have a number, again, I talked about Albuterol as being our primary rescue medicine. We have a whole number of different controller medicines that have different brand names and are used in different kinds of settings.
Mm-hmm.
Now what I have here is the other important adjunct to the use of inhalers. So here's a typical inhaler, and this is, this is nothing. This is just this is what we use for our demos. There's no medicine in here. Okay, but so what you do is you shake the inhaler, and then when you squeeze it, you can see. I think you can see that there's something coming out. Okay. Now, the best way to ensure that this medication actually gets into your lungs, and this is true whether you're a little child or whether you're an adult, the best way to make sure this medicine gets into your lungs where it needs to go is by using it along with one of these kinds of, we call them valve holding chambers or spacers, okay? And what you do is you just put the inhaler into the valve holding chamber, and then you put your mouth on, again, this is the type that we use for older children and adults, and they just put this in their mouth, and then they activate the inhaler, and then just breathe in slowly through the spacer in this kind of way, or the valve holding chamber in this kind of way. And the reason why this is more effective is, number one, people don't have to worry about timing their inhalation to go along with the activation of this meter dose inhaler. But the other reason is that when the medication goes into this chamber, the particles become smaller and better able to penetrate into the lungs. Okay, so even if you are coordinated to be able to take a deep breath well, the medicine is still going to get into your lungs better if you use something like this. Now, in children, we use these kinds of spacers or valve holding chambers with a mask so that the child doesn't have to cooperate and keep their mouth around it where they need to go. So again, though, it's the same thing. You just put the meter dose inhaler into the valve holding chamber, you put the mask on over their face, and we have different sizes. We actually have even a larger one for larger children who, for whatever reason, may not be willing to cooperate. This is one that usually is smaller children and older infants, and this is one that's really for smaller infants. And then you just put this over their face, and you just let them breathe after you squeeze this. And so if you use these sort of valve holding chambers, these are able to deliver medication just as effectively, if not more effectively, than nebulizers. Now, many people are familiar with nebulizers, and there's a general feeling amongst a lot of people that nebulizers work better than meter dose inhalers. The scientific evidence actually shows that that's not the case, that these meter dose inhalers work just as well. I think if somebody prefers to use the nebulizer, is for whatever reason, it's their right to decide that they want to use one. But in general, as I said, these meter dose inhalers work as well. They're faster, they're more portable, and when it comes to the use of the different controller medicines that I have available to me as a physician, I have a number of different controller medicines which are only available with the meter dose inhaler, and they're not available through a nebulizer. So I have more choices regarding the kinds of medicines I can give to a child if they're using this sort of spacer.
Are those spacers new? When I was in elementary school, I never saw them. It was always just that.
That may be the case, but they've been around for a while.
Right. And we actually did get a question that you answered before I had a chance to ask it. So thank you, Katie, for your question. She asked, "Why does my child have to take a controller medicine every day?" And I think you really covered that. So.
Right. These controller medicines really only work if they're used on a regular basis. And so I know we do have a lot of people who express concern that why should I have to give my child medicine every single day if they only have a mild problem or no problem at all except for when they get sick. But this is really the way the medicines work. And if you really want to optimize your child's lung capacity and you want to ensure that they're not going to get really sick when they get their colds or are exposed to whatever triggers, if the doctor has prescribed the controller medicine in order to accomplish that, really it has to be used on a regular basis to work best.
Great. And we have another question about controller medicines. This was from one of the parents of a child who's treated here. She said, he said, "I heard that controller medications are steroids. I worry about the side effect of steroids." Can you address that?
Right. So steroids are very powerful anti-inflammatory medications, and I think most of us are familiar with their use in a whole variety of different circumstances and are aware of the side effects if somebody's taking steroids systemically, meaning by mouth or shots or something like that, on a regular basis. You gain weight, the shape of your face changes, it has an impact on your blood sugars, it can affect your bones, it can affect a number of other organs. The steroids that are used as control medications in asthma have been very specifically designed so that they work inside the bronchial tubes where they're going, and there is very little of that medication that gets absorbed into the system. Again, it turns out that if you use those controller medicines with the valve holding chambers, with the spacers, then more of the medicine gets into the lungs and less of it gets anywhere else. If you're using the inhaler just in your mouth, you end up swallowing a lot of the medicine, and some of it does go into your body. So the side effects of the steroids that are inhaled are really very, very limited. Now there is a very small amount that may be absorbed into the body, but the overall effects the side effects are very small compared to the benefit that we get. Similarly, I just want to say, sometimes when children do have an acute exacerbation of asthma and have a lot of difficulty with their breathing, we will give them a short course of a systemic steroid like prednisone that they take by mouth. And if you just take it for a few days, again, the side effects are relatively small. But if somebody is repeatedly getting courses of those oral steroids because they keep on having their exacerbations and getting sick, then there really are potentially side effects that come from that. And there's no question that the use of the inhaled steroids as a controller medicine is going to be much safer and associated with much less side effects than the systemic steroids.
Okay. A good preventative medicine.
Yes.
Sounds like. Another question that we have from a parent about controller medicine: I'm afraid that my child will become dependent on the controller medicine if they take it every day.
Right. So we do sometimes get people telling us that, expressing that as a concern, and you know, I think, and so sometimes what they'll say is, well, I think maybe if we just let them tough it out, then that'll strengthen them. It's usually the fathers who say that, but so it's just not true. So the medication, the use of the regular medication doesn't do anything to weaken the lungs. If anything, the use of the medication strengthens the lungs, partly because, again, it allows the inflammatory condition to be eliminated. But also, if somebody is taking the medicine, then they're better able to exercise, and they're better able to do all the things that they want to do. Again, that sort of exercise is going to strengthen them much more than making them tough it out will, because really, if they are having significant symptoms, they're just going to be, they're not going to want to do things. This is what ends up happening. A lot of kids who have asthma end up being couch potatoes because if they go out and try and play with their friends, they have trouble keeping up.
Right.
And so they say they don't want to do it. They'd rather stay inside and do whatever is going on inside. So the best way really to strengthen a child's lungs is to treat them appropriately and let them exercise and let them strengthen themselves in that kind of way.
Great. So it's not going to make a child dependent on the medicine, and it's also going to actually make their lungs stronger in the long run.
Right, and make their overall body stronger because they'll be able to exercise.
Excellent. Looks like we have another question. Katie commented, my child likes the Albuterol better than the controller because they feel it working. Is it bad to use the Albuterol more than the controller?
Right. So it really is, and if we're gonna,
yeah.
yes, it's Albuterol, but
Albuterol.
so, but Katie, you know, again, the discussion about can you get used to the medicine, or you know, will you become dependent upon it? If anything, that is what happens when you use too much Albuterol. If you use Albuterol on a regular basis, then the lungs do get a little bit more accustomed to it and don't respond as well as they would if it's only being used intermittently. And the other thing is that actually the controller medicines make you react better to the Albuterol. So we really try to minimize the use of Albuterol. Again, we want somebody to use it if they need it, but we really want it to be so that they don't really need to use it that much. because it's not a good way of controlling your asthma because it keeps on wearing off, and so that means you can't get too far from the inhaler, right? If it only lasts for 4 hours, you have to keep on going back to it. The more you use it, the less well it works. And the other thing is it doesn't do anything to rid the body or the airways of that inflammation. And so you still have the same susceptibility to get worse when you're exposed to the triggers. So it gives you a false sense of well-being by using a lot of albuterol.
Excellent.
But it is true, it makes you feel better immediately when you use it. That's the main strength.
Mm-hmm.
And that's one of the reasons that we have trouble getting people to take the controller medicines, because they don't feel an immediate effect the way they do with the albuterol.
Right. Will children who take these medications always have to take them? Is there ever a point when they can go off medication?
We always check to see whether it's time to stop the medicine.
Okay.
And so, again, it depends on the individual children. There are some children, especially the younger ones, who have difficult winters, and then they do okay in the spring and the summer.
Mm-hmm.
So, again, contrary to your impression that it's worse
Right.
in the springtime,
Mm-hmm.
the springtime, there's a number of patients that I take off of the control medicines in the springtime, because once we get out of the season with lots of colds, they actually do pretty well. And so maybe from May until the end of August, we may take them off of it, and then when we're back in the cold season, they'll restart it. So there's those kinds of children, and then there really are some children, a number of children, maybe even most children, who do outgrow the asthma as they get older. So if we have a good year, when really a child hasn't been having any problems at all, then we'll start talking about, is it time to stop the control of medicine and see how they'll do.
And it's perfectly safe to be on the medication for a few months and then go off it and then go back on it.
Right.
No issues with that.
Right.
Okay. All right. Rosa asks, my son suffers from asthma but hates Pro Air and prefers Albuterol.
Albuterol.
You say it. Can you comment on this?
Well, it's the same thing. Pro Air is the same thing as Albuterol. And so the comment about how, so you're saying that, so is Rosa saying that her child likes Pro Air better than Albuterol, or I'm not clear what the question is.
No, her son doesn't like Pro Air, prefers Albuterol.
I see, okay.
Is that okay?
Well, again, Pro Air is a brand of Albuterol, and the inhaler may be shaped a little bit differently. The taste might be a little bit different from other kinds. It's a little bit like, Coke and Pepsi and so on. There may be some very slight differences, but they're basically the same thing. So there's really not much of a difference between